It's set up? Yeah,
Yeah,
I see the live thing. Okay, fine. I'll check from YouTube. I'll go offline for now.
okay, sir. Yes, sir. Okay, you're going to watch on YouTube?
കേട്ടില്ല വയലിലെത്തിയോ ഇന്ന കണ്ടു ആ കേട്ടു
Hello.
Yes, sir.
Hello. Audible,
Yes,
Dhanama?
sir, you're in. Yes, sir.
So shall we start?
Will you just wait for 5 more minutes, sir?
Yeah,
People
okay,
are
fine.
joining right now.
Yeah.
Thank you, sir. Yes, sir. Yes, sir. Yes, sir. Just a few more minutes, sir. All of you, please mute yourselves.
Mute.
Sir, shall we start?
Wait பண்ணுமா start பண்ணுவோமா?
We can start, sir.
Okay, fine. Sure. So good evening everyone. Actually இன்னைக்கு நான் டேட் சொல்லும்போது எனக்கு I didn't know that today is Friday was Christmas actually. So anyway, Merry Christmas to all those who celebrate. So we shall start. I came to know that the audience will be from probably first year till final year. So I didn't know
Yes,
how
sir, I'll
to.
start now.
Yeah.
Wisdom is not a product of schooling. Wisdom is not a product of schooling, but of the lifelong attempt to acquire it. Good evening and Merry Christmas, one and all. I take immense pleasure to welcome you all on behalf of AMSA India to this state-level webinar on cranial nerves. There's no scientific study more vital to man than the study of zone brain. We cordially gold medalist, who is one of the finest neurosurgeons and a great philanthropist. He's always a lending hand to students. Thank you, sir, for readily accepting our invitation and joining us today. I'll leave the rest to you, sir.
Yes. So I was confused how to start training news over to 4 different batches. Then I thought, okay, so you people are being into the new pattern of our curriculum wherein the applied things are more given more importance than the pure basic things which we used to learn right from first year till final year. So when we were students, first year we were called as basic sciences first year, then first clinical year, second clinical year, and then final year. So then first 1.5 years we were taught fully anatomy, pure anatomy, and just a little applied anatomy. Whereas in clinical years, first and second clinical years, the basics were revised and clinical aspects were taught. And in final year, it was purely clinical with some questions from basic. But now there is a change in the system of education, the pattern of teaching, and how to approach. So this system actually, I strongly believe this is a better system. You people are taught applied clinical sciences right from your basic. So even some first clinical, no, or is it first year students of our college had come last year to our department in 2 batches, and I had demonstrated some clinical science. So bearing that in mind, I thought that I could do the same to this group also. So wherein the importance will be given for clinical examination as well as some science. So doing cranial nerves in 1 hour is not possible, because cranial nerves we can teach for 10 days or 15 days. So I thought at undergraduate level, most important clinical science pertaining to different some of the nerves. So I had taken around 7 to 8 nerves. So I had taken around 7 to 8 nerves and chosen them in a way that from a student's perspective, these are the common things which are missed by us when we were doing our undergraduate. Because so I had given emphasis in that aspect and prepared this. So we shall start now. As you all know, there are 12 cranial nerves, and I'd be discussing about only about a few. So let me start now. Is the slide visible? Am I audible?
Excuse me, sir.
Am I audible? Hello?
Yes,
Me, sir.
Yes,
Yes,
am I
sir.
audible?
Yes, sir.
Yeah. So can you see the slide?
Yes, sir.
Excuse me, sir. 1 minute.
Yes.
Sir, can you make me as the host? I made you as the host, so I couldn't let people who are coming in right now.
What has happened over there then? Wait. So should I go back? Yes. Is it all right now? Hello? Is it all right
Thank you,
now?
sir.
Yeah. Is it
Yes,
all
sir.
right?
You can start your presentation. Thank you, sir.
Yeah.
Yes, sir.
Yes. So with respect to optic nerve, one common thing which we miss, the common usual things are three things which you will test in optic nerve. So visual acuity, which is clarity of vision. Then you will test field of vision, that is the area of vision, your peripheral vision versus central vision. And the third one is you will test color vision. So these three things usually we do. And one thing which we tend to miss is the findings in the light reflex. So the findings in the light reflex which we tend to miss, because usually out of the 50 odd cases you come across in clinical years, you will find that the light reflex will be preserved and it will be normal, it will be equal on both sides. But the one catch question which may be there in your case is an afferent pupillary defect or a relative afferent pupillary defect, which is called as shortly as RAPD or Marcus Gun pupil. So here the thing is, you shine light on one side, both the pupils constrict. This is normal. So you have a direct reaction on the ipsilateral eye and consensual on the contralateral eye. And when you shine the light on the opposite eye, then again both will contract. So this reflex will be normal when the afferent pathway, both optic nerves are normal, and the efferent pathway, both the oculomotors are normal. So now in RAPD, what happens is one of the afferent pathway, that is one of the afferent pathway in the sense one side optic nerve is diseased or there is some problem along that pathway. So how do you find this? So you will see in the next demonstration. Is it audible?
Yes, sir.
Kindly mute yourselves.
So this is where the point is, when we shine light in the affected side, so we don't have enough impulses to reach the reflex center, and from the reflex center back again to both the oculomotor nerves. So when the light is shone on the affected side, the signals don't reach both the eyes, efferent pathway. So when we shine the left eye, the left optic nerve does not carry enough impulses so that both the direct and consumption reflex will be affected. So when the swimming flashlight, the torch light is shifted from one eye to the other eye. So for example, when the torchlight is shone on the right side or normal eye, both the pupils will be constricting. Now, in a normal eye, when you shift the torch to the opposite eye, that is the left eye, if it were normal, then again, both the pupils will be staying constricted. They will stay constricted because the left eye pathway is, afferent pathway is also normal. But what happens in diseased eye, when you start to shift towards the affected eye, the strength of the stimulus is decreasing because the left eye cannot, the left eye isn't functioning properly. The afferent isn't functioning properly. So the constricted pupil, instead of staying constricted, starts to dilate. So this is a paradox because we expect eye to constrict when the light is shone on it. Here the paradox is, relatively, when you shift the light from one eye to the other, the pupil starts dilating. So this is a relative afferent pupillary defect or Marcus Gen pupil. One thing which you have to remember during the rest of your life is RAPD occurs in lesions anterior to chiasma. The chiasma is the crossing of fibers from both the eyes, which you are all aware. So RAPD occurs in lesions anterior to the chiasma. It can occur in retinal detachment. It can occur in various glaucomas. It can occur in optic neuritis, etc. So most commonly, undergraduate level, RAPD is an optic nerve pathology, and the common condition is you can have multiple sclerosis. Then when it is a stroke, you can say it could be due to occlusion of the central retinal artery. So this is about RAPD, which we tend to miss because when you are examining the eye, when you just look at the eye, both the pupil will be constricted because the light from the normal eye is keeping both pupils in the mid constricted position or whatsoever. So if we fail to test it by swinging the light from one eye to the other, we will easily miss. So this is the catch point. So when RAPD is kept, probably when the system of examination changes during your final year, you will have more of Oxy type of questions wherein this could be kept. Ophthalmology also you can get, even in CNS also you can get. So this I wanted to stress about second now. Okay. Then one another important thing which I wanted to stress is commonly extraocular movements. So extraocular movements are subserved by third cranial nerve, fourth cranial nerve, and sixth cranial nerve. Even here, so usually you test extraocular movements in each eye individually. Extraocular movements are tested in each eye individually. So common mistake which we do is we fail to test each eye individually, and when we test the second nerve during our testing of peripheral field of vision, we may assume that both the movements are all normal. So even in extraocular movements, it is very important to test each eye individually by covering one eye. The movements of each eye, when you test individually, are termed as duction movements. And when you test both eyes simultaneously, you are testing the gaze or version movement. So duction is when you test individual eye, version is when you test both the eyes. So with this I stop. So duction movements are tested. Duction movements are tested in each eye individually. And as you all know, you will be aware of the 4 recti and 2 oblique eye. Excuse me. So the superior recti, inferior recti, medial rectus, and lateral rectus. Lateral rectus is supplied by abducens nerve. Superior rectus, medial rectus, and inferior rectus are supplied by third nerve, whereas the inferior oblique is supplied by the fourth nerve, and superior oblique is supplied by the third nerve. So you mean while you are testing each eye individually, it is duction movement, and you test both eyes simultaneously, it is the gaze. So both are different. So gaze has a gaze issues in gaze have a different neurological localization, whereas individual eye movements, when they are affected, they have different localization. So it is very important to test each eye separately. People forget and they test both eyes simultaneously and think that both are normal, or they fail to they fail to test the individual eyes and they miss certain things which differentiate it from gaze palsy, from problems pertaining to individual eye, nerve supply, or muscles. So once again, one thing to remember is, so you have a mnemonic. So intorsion, extorsion. So intorsion, extorsion, it is subserved by these are the accessory actions of your recti and oblique. So you can have a mnemonic as sin. Sin, superiors are intortos. Superiors do intorsion. Superiors do intorsion. Inferiors do extorsion. So sin, S-I-N, sin. Superiors, intorsion. Superior rectus and superior oblique, they do intorsion. So the opposite of superior, inferior, is extorsion. Inferior oblique and inferior recti do extorsion. Similarly, the recti are adductors. The recti are adductors. So rad, R-A-D, rad. So recti adduct. Okay, so superiors are intortus and recti are adductors. So automatically oblique are abductors. So oblique air abductors, recti air adductors. So in gaze, what is primarily happening is you move both eyes simultaneously towards a target. Okay, so the target may be a fixed one or a moving target which your brain is trying to fix. So that is the purpose of gaze. So a person is walking towards you or walking away from you. So you try to fix, you try to see the person so that now the movements of the eye are adjusted such that the image of that person constantly falls on both the macula simultaneously. So the brain adjusts the finer movements of the extraocular muscles of both eyes so that the object is fixed in your visual fields constantly, whether you are moving or the subject is moving. Okay. So this is one. So now in gaze, we have two things primarily. So one is a saccade and the other one is a perceive. Saccade and perceive movements are common gaze movements. So where a saccade is one wherein you shift the focus at an instant. You shift the focus at an instant. So you'll be looking at a field, an area, or some other object. Another object crosses the field. Another object crosses the field, or you are visually distracted towards another stimulus. That is, if you people you are listening to the class, suddenly something falls in front of you making a huge noise. So in front of you making huge noise. Now what happens is, instead of while watching the device, you tend to try to look at the object which has fallen or which has caused the noise. Saccades. These saccades are primitive eye movements. Saccades are primitive eye movements. These were designed to protect the organism from predators. That is, the deer or cattle will be grazing. So when a predator comes, they get visual cues or something they sent, and they have to shift the focus from their field instantaneously on the area of danger. So where they perceive the threat, their eyes have to shift focus. So this is saccade. So commonly when we are listening to the class, somebody else, someone known to you or whom you like passes along the corridor, everyone will be tempted to look towards the corridor. So that is saccade. And perceive movement. Perceive is the second thing where after the saccade, that is, you have fixed the new target and you have the intention to follow it. If somebody is coming, you get distracted, you have a peep at them and continue to follow them instead of your primary work. So that is pursue. So pursue occurs when you need to focus upon the new target. So pursue occurs when you need to focus upon the new target. Is this video clear? Hello? Hello? Here the examiner asks the patient to look at the torch when it is glowing.
Yes, sir.
Look, he is asked to look at the torch, but his eyes aren't moving. Okay. So now this is the second part. This is whenever we ask a patient to look towards a target, he won't be able to look towards that. So here in the initial normal subject, you could see that when she was asked to look to the right or above, up or down or to the side, she was able to do so. But this patient, the diseased patient, he couldn't voluntarily look towards his right or left or above or below. So this is, as I told, gaze palsy. So in this very same patient, if you think that, so this gaze palsy, when we ask the patient to look towards right, he's not able to do. So the probable reasons could be the nerves which cause contraction of the muscles that look towards the right may be at fault, or the muscles that perform that movement could be at fault, or the gaze center could be at fault. So these three things could be at fault. When the nerve is at fault, you won't have any movement at all. When the muscle is at fault, even then the nerve is giving the stimulus, but the muscle cannot work because the muscle is at fault. So when the gaze center is at fault, the nerve is intact and the muscle is intact. So the gaze center is the center which is directing you to look towards the right, is at fault. So now when you command the patient to look towards the right, he is not able to do so. But actually, now you remember what I told, if you got to test the individual eye movements in him, you cover one eye and test the other eye individually, he will be able to look above, below, sides, etc. But simultaneously, when he has to look towards the right or left, he won't be able to do. So in a gaze palsy, you should remember that the conjugate eye movements are lost, whereas individual eye movements will be largely preserved. So when individual eye movements are lost, you won't have gaze also. So that is evident, because when a single eye cannot move due to local pathology or a nerve palsy, it won't be able to move even when you try to have a gaze. So a gaze palsy, the patient's eye will not move when he has to move both eyes simultaneously. For example, if you ask him to look towards the right, he won't be able to see towards the right. His eye don't move towards the right. For eye to move towards the right, you need the right side lateral rectus and the left side medial rectus to work. So this is basic. So right side lateral rectus and left side medial rectus to work. So in gaze palsy, he won't be able to look towards the right. Whereas if you cover left eye individually, if this patient has a gaze palsy towards the right, but his nerves are normal and his muscle is normal, okay, all his muscles are normal, then he will be able, his right lateral rectus will be functioning, as well as in the left eye, his medial rectus will be functioning if you test them individually. So this is the difference. In gaze palsy, you test the eyes individually, he will be able to look, okay, towards all sides. Whereas if it is a palsy of the sixth nerve on the right side, if it's a palsy of the sixth nerve on the right side, his right lateral rectus will not work. So in the primary position itself, when he is asked to look straight itself, his eye will be deviated towards his right eye will be deviated medially because his right lateral rectus is not working. So even if you close the eyes and ask him to look towards the right, he won't be able to do. So in gaze palsies, conjugate gaze movement will be affected, whereas individual movement will be usually preserved. So this is for undergraduate level. There are certain conditions wherein you can have a combination of both, but at the undergraduate level, this simpler thing will do. Gaze palsies, conjugate eye movements will be lost. You test individual eye, the movements will be preserved. In nerve palsy, individual eye movement will be lost as well as conjugate gaze will be lost. Okay. Now coming to that vestibulo-ocular reflex or doll's eye movement. Here again, this is it is an involuntary gaze. It's like an involuntary gaze where when you keep your head still and you are asked to move, the patient is asked to move his eyes to the right and left, he is not able to move. But when you turn his head right and left, his eyes will tend to move away. When you turn his head towards the right, the eyes will go towards the left, and when you turn the head towards the left, his eyes will go towards the right. That you could see that evidently. This is again a primitive reflex which will be lost in deeply comatose patients. So doll's eye movement, this is called VOR or simply doll's eye movement. Doll's eye movement is lost when it will be lost in deeply comatose patients. So midbrain lesions, any lesions in midbrain and above, that is when the cerebral hemispheres are totally dysfunctional or in deep coma, doll's eye movement will be lost. Yeah. Yeah, here again, so this is basic. So frontal eye field is the higher center for your gaze. Horizontal gaze, there are two centers. One is a lower motor neuron center, that is in the pons, and another one is in the upper motor neuron, that is the frontal eye field. So frontal eye field controls the gaze at the UMN level, and centers in the pons and midbrain will control the gaze in the at the lower motor neuron level. So now for gaze, I told no, for visual fixation is the main function for gaze. So the impulses which are sent from the retina to the occipital lobe, you will form an image, and for that image to stay clear, and for the image to be focused, you are adjusting, the eyes are adjusting. So for that, impulses from the occipital cortex travel to other areas, visual association areas, we call them 18, 19, and from them they go to the frontal eye field, which is the motor area, UMN motor area for gaze. So from right frontal eye field, remember this is a UMN. So from right frontal eye field, the fibers, the impulses will travel and supply the left lower motor neuron. So left lower motor neuron, which is the lower center for gaze, is PPRF, parapontine reticular formation. So PPRF is the LMN gaze center, whereas frontal eye field is the UMN gaze center. So frontal eye field is UMN gaze center, PPRF is LMN gaze center. So right frontal eye field sends its impulses to the left frontal eye field. So now I have a question for people. So what is the basis of UMN innervation to the opposite side? Anybody? So we know right side, if you have to move our right upper lip, impulses have to come from the left cerebral cortex, that is left motor cortex. So when you want to use the right leg, impulses have to come from the left motor cortex. So what is the basis of this? Anybody? Anyone? Hello? Am I audible? Hello? Hello?
Yes, sir.
Yes, sir, you're audible, sir.
Yes.
In
So if you have,
pyramidal acquisition.
yeah, pyramidal deposition, I'm asking what is the basis?
Embryologically.
No, not like that. The thing is, if you have to move your left biceps, your right cerebral cortex has to work. Okay?
Yes.
So if you have to turn your head towards the left, impulses have to come from the right. If you have to turn your head towards the left, impulses have to come from the right. What is the basis? Can anybody tell me, when you are asked to turn your head towards the right, which are the muscles are working? When you are asked to turn your head towards the right, which are the muscles working?
Opposite actions of the muscles.
Sternocleidomastoid.
Which sternocleidomastoid is working? I am
Left,
asking you to
left side.
turn the head towards the right side. Okay, right
Left.
side. If I ask you to turn, which sternocleidomastoid is working?
Left side is contract.
Left sternocleidomastoid is contracting. Okay. Now, when coming again to the previous question, if I have to move my head towards the right, impulses have to come from which cerebral cortex?
Left side.
Now you have a contradictory thing. The left cortex is supplying the same side muscle. Is it not?
Yes.
Is it not?
Yes, sir.
When I have to flex my right upper limb, where am I getting the impulse from?
Left cerebral.
Left side. When I have to flex my left upper limb, I am getting impulse from the right side. But when I have to turn my head towards the right side, I am getting impulse from the
Right side. Same side.
So right side to the opposite. So the point is, it is not individual muscle that has to be supplied from the opposite cortex. The point is opposite side muscle movements. Okay, opposite side, not muscle movements, it is movement. Opposite side movements are controlled by one cerebral hemisphere. Remember that. Okay, if I have to move my tongue towards the left, I should have impulses from the right. If I have to turn my head towards the right, I should have impulses from the left cerebral hemisphere. So remember this. The opposite side movements are controlled by one cerebral hemisphere and not individual muscles. Remember this. Okay. Hope you are getting. So now the what is the right frontal eye field? It sends impulses to the left parapontine reticular formation, and from there the local what is that nuclei for medial rectus, lateral rectus, they get activated, and for impulse from right frontal eye field, you will tend to look towards the left. So for you to look towards the left, you need your left lateral rectus functioning. So right frontal eye field controls the left lateral rectus. At the same time, the right frontal eye field is controlling the right medial rectus. Do you get me now? This is what I meant. If you have to look towards one side, impulses will control that movement from opposite cerebral hemisphere. So now from right frontal eye field, the ipsilateral medial rectus muscle is supplied, whereas contralateral lateral rectus is supplied. Hope you all get me. Is it not? So the cerebral hemispheres control the opposite side movements. Okay. So that you should remember. So, okay, this I didn't want to actually emphasize, but I had to do. Okay. So here, impulse from the right frontal eye field is reaching the ipsilateral side muscle, okay, through some connections. So remember always, the opposite movements are controlled by one cerebral hemisphere and not necessarily opposite muscles always. So this holds good for our eye movements as well as our head movements. Okay. So, okay, this will do. Okay. One another thing I wanted to stress in eyes, or can you see what has happened in this eye? The boy is looking straight. What has happened? Anybody?
Right medial rectus.
Right middle rectus?
Have some problem.
No problem. Okay. So you assume that it looks that right middle rectus has some problem. Okay, because the right eye is deviated towards the left. Okay.
Left.
Now you look at the next video carefully. Can you see any other abnormality in the eye? Can you see anything
Left eye
else?
is not left eye is not completely adducted.
Okay,
Pupil size
fine,
is-
that's good. Pupil is?
No, dilate.
Different size on
On
right.
right side, the pupil is
Yes, good.
totally
You could observe that, is it not? So, which pupil is dilated?
right side.
Right side. Okay, fine. So now, Can you see? This pupil is, what has happened? Can you see it? Can you observe? One minute. So here in the right eye, that pupil was dilated. Can you see that? Right eye pupil. This is left eye pupil is reacting, whereas the right eye pupil is dilated. Can you see? Right eye pupil is dilated and it is deviated towards the side of lateral rectus. So this was a case of complete third nerve palsy. So the right eye pupil was dilated, not reacting, and the it is deviated towards the unopposed action of right lateral rectus. Okay. So one another important one is for undergraduate level is lesions of seventh nerve. So what do you see here?
Left-sided palsy, facial palsy.
Yeah, left-sided facial palsy. What is the facial palsy? LMN or UMN? This is what you will be kept. You will know. You have to differentiate lower motor neuron or upper motor neuron.
Upper motor neuron is
How do you say it is an upper motor neuron?
complete
You say it
quadrant.
is a. You mean to say it is a left-sided upper motor neuron? Is it?
Complete quadrant. 2 quadrants of the left side is lost.
2 quadrants of left side is lost. Okay. Now people are you people are telling it is a left-sided facial palsy. Is it not? Anybody else?
Sir, right side palsy, sir.
Unopposed action.
Right-sided facial palsy. Very good. What is it? Is it an UMN or an LMN?
Sir, LMN, sir.
Why do you say it is LMN?
Sir, inability to complete closure of the eyes.
This is most important point. Can you see that? The eyes are, you could see the sclera, which is visible on the right side, whereas in the left side, the eyelids are shut tight. Okay. Then loss of nasolabial fold on the right side, and the eye and the mouth, what is it, the angle of mouth is deviated to the opposite side. So these three features will say it is a element type facial palsy. In element type, the upper half of the face is also involved. In UMN type, the upper half of face is paired because it has bilateral representation. Here again, bilateral representation for both sides of face in the upper half alone. The upper half of the face has bilateral representation from both the cerebral hemispheres. So even when one cerebral hemisphere is at fault, you have stroke on the right side brain. If it is an UMN lesion, before the fibers reach the seventh nerve nucleus. So any suprapontine lesion, any lesion above the pons, the impulses to the pontine center are coming from both the cerebral hemispheres. So you won't find any weakness in the upper half of the face. Any pontine and infrapontine lesions, lower motor neuron, pontine and infrapontine lesions, you will have the upper half of face also involved. So simply upper half of the face is paired in UMN lesion because it has bilateral representation, and upper half of face is involved when there is a LMN lesion. Okay, now observe closely. He's closing his eye. What is happening when he is closing his eye?
Bell's phenomenon.
Bell's phenomenon. So what is Bell's phenomenon?
His eyeball is moving towards his eyeball.
Eyeball is
Uh,
rolling
Moving
upwards.
upward and outward.
Upside.
Not necessarily outward. Eyeballs will normally, when we close our eyes, the eyeballs will normally move upwards. Okay. In facial palsy, as the eyelid is not closing, you are able to see that outside. So that is Bell's phenomenon. Bell's phenomenon is a normal phenomenon which occurs when we close our eyelids. When we are asked to close our eyelids, both of our eyeballs will move upwards. But here in facial palsy, lower motor LM and facial palsy, you are not able to close the eyelid. So this upward movement is visible to us. So it is just visibility of a normal phenomenon, which is Bell's phenomenon. It is not that in facial palsy alone you have upward rolling of eyes. It's not so. Upward rolling of eyes occurs when we tend to close our eyelids. That is happening always. It is visible outside when our eyelids are not able to close, and that signifies a LM palsy. And here again he has nasolabial furrow obliteration. Eyes, what is that? His angle of mouth is deviated towards the normal side. Okay. Watch this carefully. So here his upper half of face is pad. Okay. He is able to raise his eyebrows. This is the right way to do a corneal conjunctival flex. One thing is, the thing that is not done properly is, anybody? What is wrong? Can anybody say what is wrong there?
Sir, should not go from front menace reflex.
Yeah. The examiner should be examining from the sides away from the visual field. Okay. Patient's visual field you should not cross, because when you try to do it from the front, a reflex called menace reflex occurs. You know, if somebody suddenly points a finger at your eyes, you will blink, is it not? If somebody suddenly points a finger at your eyes, comes very closer, suddenly we try to close our eyes. This is a protective reflex again, menace reflex. You may notice dust will when we anticipate some dust or something, reflexly our eyes will close. That is because it is a menace reflex. It is observed through your visual pathway, the visual cortex. No? From there, this reflex is observed. So while examining for a corneal reflex, stand by the side of the patient. Corneal conjunctival reflex. Stand by the side of the patient or from behind the patient and come away from his visual field. Don't point directly in the center of his field. So that is not right way. Now you may find that the corneal reflex is positive. You may think it is positive. So always while examining corneal reflex, stand from the side of the patient or from the back of the patient. So this is upper motor neuron lesion where the patient was able to close his eyelids tightly. Okay, corneal reflex was preserved and he was able to frown or look above. So the upper half of face was spared and the lower half of face there was deviation towards the left side. So here again this is a right UMN palsy. So you saw one right UMN palsy, previous one right LMN palsy. Yes, you could see this. Here again you can observe she is able to close her eyes tightly and her angle of mouth is deviated towards which side?
Left. Left.
Left. So this is again a right UMN palsy. Okay. So always be clear about UMN and LMN. LMN palsy, one half of the face is lost. UMN palsy, upper half is spared because it has bilateral representation. So one more question. In case of bilateral or otherwise I'll say in case of upper motor neuron lesion, what will happen if the patient is suddenly crying or laughing out subconsciously? Anybody get my question? So UMN lesion is there. The eyes are not eyes. The angle of mouth is deviated to opposite side. Now the patient involuntarily laughs. Somebody has cracked a joke. From her heart she laughs or cries suddenly. Now what will happen to the lower half of the face?
Sir, emotional components preserved, so there will be no angle of mouth deviations.
Yes, hope everybody has understood. So in UMN lesions, there is a separate pathway which supplies the facial nerve nucleus from the emotional pathway. So in UMN lesions, when we subconsciously laugh or cry, the fibers from the emotional pathway will activate the lower half of face also. So you won't find any angle of mouth deviation when the patient is crying subconsciously. That will be for certain instant only, after which the impulses from the pyramidal tract will lower. So emotional pathway is preserved even in UMN lesion, and in UMN lesion also this emotional pathway is blunted in certain conditions, where if you ask the patient to voluntarily smile, okay, voluntarily smile, he will have deviation. If you ask him to voluntarily smile, he will have deviation, but at rest he won't have deviation. So this can occur in certain dementias and extrapyramidal syndromes, but this is not needed for undergraduate level. For your undergraduate level, remember UMN facial palsy, upper half of face is spared, okay, and emotional component will be spared, wherein involuntary, your subconscious laughing or emotional stimulus, you won't have any facial deviation. Am I clear about LMN and UMN? If you want me, I'll run the videos again. Anybody? Okay. So I assume you have understood. So we will move on to the next one. So this one, this we have already described. So you could see the cortical bulbar fibers from one tract, they supply both sides of the face, upper half, whereas for the lower half, you will get only from contralateral side. So that is why sparing of upper half occurs. Okay. fine. Yeah, then two more things I wanted to teach you. So this one is important. I'll do this also. Can we proceed?
Yes, sir.
Okay, fine. So trigeminal common things you know. So always remember this. So the trigeminal nerve has 3 sensory nuclei and 1 motor nuclei. So at undergraduate level, you need to know mesencephalic tract. It carries proprioceptive fibers. Neck movements, facial movements will be carried to mesencephalic nucleus. Principal sensory nucleus is in pons. It carries touch fibers, whereas spinal nucleus is in the is the longest descending nucleus of the trigeminal nerve from medulla to cervical segments. Okay, it carries pain and temperature sensation of the face. So this you have to remember. Has anyone heard of onion peel distribution? Onion peel distribution. So this one I wanted to emphasize because this is commonly missed. You ask the patient whether he is able to feel the touch. He will say, yes, I am able to feel the touch on both sides. But when you test for pain and temperature, one side he won't be able to feel. So you will miss a diagnosis of anybody. Patient is able to feel the touch on his face both sides. But when you test for pain and temperature, one side of the face is not able to perceive pain and temperature. This occurs in
Syringomyelia.
It can occur in syringomyelia or syringobulbia. So dissociative sensory loss. This you may miss. Undergraduate level you may miss. So this is what I want to emphasize. This is called as onion skin appearance. So this you will know. So remember this topography of the fibers. So ascending fibers will carry touch and pressure sensation and they reach the principal sensory nucleus of the pons. Ascending fibers carry touch and pressure sensation and they reach the principal sensory nucleus of pons, whereas descending fibers carry pain and temperature along the spinal nucleus. This is a long nucleus which extends right from medulla and it can go up to cervical segment C1 to C4. That is why, due to this distribution, even if you have a spinal cord pathology at C1 to C4 levels, you might have sensory disturbances in the face. Okay, because trigeminal nucleus is a descending nucleus. It comes up to C2 or C4 levels. So remember this. So you need not have a lesion exactly in the trigeminal nerve for a loss of sensation in the face. You can have a spinal cord pathology which is totally unrelated anatomically. When you think, so spinal cord C1 to C4, we may think it does not supply anything in the face because C1 to C4 C4 does not supply anything in the face as such. C1 supplies what? C1 sensory supply. Anyone? C1 sensory supply.
Meninges over posterior cranial fossa.
Meninges over posterior cranial fossa is supplied to C1. C2 is supplied in the suboccipital region. C3 supplies the collar region where our shirt collar is there. So even in lesions of spinal cord at C2, C3 level, you may have sensory loss in the face. So that explains this because the trigeminal nerve nucleus, spinal nucleus descends downwards up to C4 level. Here again, the topography is important. You could see here fibers from the nose and the lips. Okay, spinal nucleus you can divide as 3. Rostral part or the part near the medulla, then nucleus interpolaris, the thing between medulla and the spinal cervical cord, and the spinal nucleus which runs from C1 to C4. So you can divide arbitrarily into 3. Okay, upper half, rostral half stays in the medulla. The lowest half is in the cervical region, C1 to C4, and the intermediate part. So these three. Now the fibers from the nose and lips will terminate in the rostral half of the medulla, and the fibers which are next, you could see the green one, they will terminate in the nucleus interpolaris. Then the fibers which are posterior to that will terminate lower down. So from center of face to periphery, the fibers from the center will be occupying the highest point in the spinal nucleus. The peripheral most areas will occupy the lowest point. Now what happens if you have a lesion in the lower part of the spinal nucleus? What will happen? Lower half of the spinal nucleus, the blue part that is observing the function for the that function is observed by the lower half. So when the lesions in the cervical spinal cord, because the fibers from the peripheral most parts come to the cervical spinal cord, any lesion in the cervical spinal cord, you will have loss of pain and temperature in the peripheral areas, that is in front of the ears, just posterior to the outer canthus. In front of ears to posterior to the outer canthus, you will have loss of pain and temperature, whereas you will have preserved pain and temperature in the nose, around eyes and lips. Do you get this? So the more lower the lesion, the more peripheral the sensory loss. The more lower the lesion, the more peripheral the sensory loss. If the defect is in the upper half of the spinal nucleus, that is rostral part, the sensory loss will be in the center, whereas the periphery will be preserved. So now when you are examining touch, if you examine, it will be preserved in all areas because touch has nothing to do with the spinal nucleus. Whereas pain temperature, the upper half of the spinal nucleus observes the center part, whereas the lower half observes the peripheral part. So now when you miss examining pain and temperature, you will miss the site of lesion. So while you're examining the pain temperature, if the sensation is lost around the tip of the nose and mouth, where is the lesion? If the sensation is lost in the tip of the mouth and nose, the lesion is
Pars oralis.
As oralis.
pars oralis or higher up. You can have as higher up. It is around medulla. Okay. So the pars oralis, or it is higher up in the medulla. When the sensory loss is in the periphery, you can assume that the lesion should be down. Okay. So this is the catch point. So if we just examining touch, we may just examine touch and see it will be normal on both sides because the nucleus is far high. Whereas when you examine pain temperature, if there is discrepancy, you will localize the lesion. Otherwise, you will miss the localization of the lesion. So this phenomenon is called as onion peel sensory loss. The onion peel sensory loss can be either in the center or in the periphery. The arrangement of the fibers is like onion peel. If you look end on, it will look like peels of onion. So you can understand this. This one you can remember. I hope everybody is aware of this. What is this? Formula 1 drivers and MotoGP drivers used to wear this fire suit. No, the fire suit, it will be closed all over except the area which we assume to be supplied by the rostral part or the oralis of the trigeminal. So this you could understand, is it not? Okay, fine. So corneal reflexes are jaw jerk. Okay. Now finally, last one. So 9th and 10th nerve. So 9th and 10th nerve commonly is tested by gag reflex. Okay. So the afferent is glossopharyngeal nerve, efferent is vagus nerve. So what you ask commonly is two things you do. One, you test when you see, when you look. So for 9th and 10th, when you look, you ask the patient to open his mouth and say, ah. You ask the patient to open his mouth and say, ah. When he says, ah, you check the position of the palate and uvula. If they are moving freely, equally, it is normal. If they aren't moving, then there is some pathology. And at the same time, you test the gag reflex. So based on these two interpretations, you will know whether it is 9th nerve or 10th nerve or involvement of 5th nerve. So in gag reflex, sensory is 9th nerve, 10th nerve is motor. In palatal reflex, sensory is 5th nerve and motor is 10th nerve. Palatal reflex, sensory is 5th nerve, motor is 10th nerve. Whereas in gag reflex, it is 9 and 10. So when you test both things, if in both tests there is no gag reflex and there is no palatal movement, it indicates the efferent 10th nerve is at risk, at fault. Because 5th nerve you would have tested, sensations will be preserved. Palate movement, palate is not moving. Gag reflex you test, there is no gag reflex. So now afferent component of palatal reflex is preserved, whereas efferent component is lost. Same way, in gag reflex, patient is able to feel the pharynx, but there is no contraction. So 10th nerve is lost. Whereas when the palatal reflex is preserved, gag reflex is absent, it indicates a 9th nerve pathology. Okay, palatal reflex is present means 5th and 10th nerve are intact. You can assume. Gag reflex, it is absent. So either 9th or 10th should be at fault. Already you have confirmed that 10th is normal by palatal reflex. So one side you have confirmed 10th is normal, gag reflex is absent. So the nerve that is at fault is 9th nerve. You could see. So here it is wrong. It is not 12th nerve. That is 10th nerve. That is not 12th. Okay, these things you don't need. So this you know. Okay. This I have told you already. Yeah. So here you could see the uvula is deviated to. Where is the uvula deviated?
Left side.
Left side.
Yeah, left side. So it is a palsy of
Right.
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 So uvula வந்து normal right side muscles will pull the uvula to the right. Left side muscles will pull the uvula towards the left. Okay. Right side muscles pull towards the right. Left pulls towards the left. So if left is weak, it is deviated to right. If right is weak, it is deviated left. Similar thing occurs in barrels. Barrels you will have same similar thing. Pulling to the same side. Occurs in louder.
Tongue. Hypoglossal. Tongue.
Tongue. Then
Brain.
tongue you have pulling or pushing.
I.
Pushing.
I.
ஐல என்னது?
Pulling.
இல்ல pulling அது எதுல போறோம்? Where do you get pulling?
Medial.
I'll give you a clue. Cerebellum, vestibular system. Cerebellum and vestibular system. Which will pull, which will push? Cerebellum and vestibular system. Cerebellum will pull towards the same side. Vestibular system will push towards opposite side. Okay, similar to palate. Palate and vestibular system. It is palate and cerebellum. They will pull towards the normal side. Okay, palate and cerebellum. You remember as police constable, palate and cerebellum. Okay. Whereas vestibular system will push towards the opposite side. Right vestibular system will push to left. Left vestibular system will push to right. Similar for caloric test. Cows, you know the mnemonic cows, is it not? Cold water opposite, warm water same side. Okay. So these are things which you relate and remember. You won't forget. Palate, cerebellum, they will pull towards the normal side. Palate and cerebellum will pull towards the normal side, whereas vestibular system will push towards opposite side. And remember cows. Okay. So this I have told you. Uvula is by 5th and 10th now. So this I have told you. So this is 12th cranial nerve. As already one person told, genioglossus is the main muscle which we test. Genioglossus pushes towards the tongue towards the opposite side. Genioglossus pushes towards opposite side. So lesions of genioglossus are one side, results in unopposed action of the opposite genioglossus. Okay. So what is there in UMN lesion? Weakness of contralateral genioglossus, deviation of tongue away from the side of lesion. Here again I told you, opposite movements. So remember movements. So right cerebral cortex will innervate the left genioglossus. Remember, right cerebral cortex will innervate the left genioglossus. Left genioglossus will push towards opposite side. So when lesion due to right cerebral hemisphere, the affected muscle is the left genioglossus. The unopposed muscle is the right genioglossus. So when the unopposed muscle right genioglossus will push the tongue towards the left side. Whereas in LMN lesion, the right genioglossus is affected. It is due to right 12th nerve. So left genioglossus will be overacting. So it will push towards the right. So ipsilateral tongue palsy, deviation of tongue towards the side of lesion. Can you understand this? Okay. Yes. So fasciculations of tongue, then atrophy of tongue, furrowing of tongue indicate lower motor lesion, neuron lesion. Fasciculations, atrophy, lower motor neuron lesion. To make things clear or for better view, you can ask the patient to open the mouth and protrude the tongue outside and look for deviation. Okay. So you can ask the patient to open the mouth, put the tongue outside and look for deviation. I couldn't adjust it. This is LMN lesion, nerve lesion.
Yes. So this you will do normally. So these are few things about tongue. A large tongue is seen in acromegaly, Down syndrome, congenital hypothyroidism. Always remember congenital hypothyroidism, then amyloidosis. And amyloidosis. Okay. Acromegaly, Down syndrome, congenital hypothyroidism. Okay. Remember this. The smaller tongue indicates usually a lower motor neuron disease. Remember motor neuron disease. So that's summarizes that. So that's the end of the class. Any doubts? Hello. Hello.
Yes, sir.
அவ்வளவுதான் கிளாஸ் முடிஞ்சது. டவுட் இருந்தா கேளுங்க. 2 minutes. I have to go outside. Hello. Hello. Okay, fine. I have given a few questions for as what to say quiz, rather the way you could understand things from a class. So you all try to answer that, and I am afraid I have to leave now. Thank you all.
Thank you,
Hope I
sir.
am audible. Yeah.
Thank you,
Thank you,
sir.
sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Participants, please don't leave. You have to fill in a feedback form, and there's a short quiz for that. The link for the feedback form will be posted in the chat now. Please fill in this form and send immediately. The second link is for the quiz. With all the correct answers will get certificate. If in case you're not a member of AMSA, in place of AMSA ID, write nil.
Hi, can we leave once we fill the form?
If you have filled the form, you can leave.
Thank you.
I have posted the form link in the group also. You can use that. I'm closing this meeting.